My pleasure to be here. Is this on? Yep. Good. Thank you. When I complained to Landon that 5 minutes wasn't really long enough to accomplish anything meaningful, he says 5 minutes has always been good enough for him. So thank you. SST, a kind of small problem which causes huge issues post-operatively with satisfaction. So we'll fly to this. Put on your seatbelt. These are my disclosures. I don't have any implant company disclosures. So I think we all know what we're talking about. We're talking about the glands falling off the corporal bodies, the shaft, typically going from dorsal to ventral, but occasionally you can have a very hypermobile glands that goes in the opposite direction. It's actually very difficult to find good literature on what the prevalence of this is. And this comes from a review paper suggesting it's about 5%. Certainly, I don't believe it's 5% in my practice, either intraoperatively or postoperatively, but not easy to find this literature at all. What's the purpose of the glands? Very interesting question, right? So first of all, it's covered in mucosa, so it's got to go low coefficient of friction, high nerve density for sensation. It's believed to act as a shock absorber during coitus to spread away the labia minora and make it easier for the narrower shaft to penetrate the vagina, and presumably likewise with the anus. Requires threshold level of turgidity, so when you have a soft gland syndrome, it makes it more difficult to penetrate. And the glands makes approximately a 20 to 30 degree angle with the shaft, and when it's more severe than that, then it becomes a problem. Causes of SST deformity, well, I think when we talk about undersized implants and incomplete distal dilation, it's very easy to understand that. But I think the vast majority of cases that we will see as good implanters is neither of those, but it's just somebody who has an innately hypermobile glands, which doesn't necessarily manifest when the patient has glands engorgement, because that mushroom shrouds the corporal bodies. But when that glands is soft, like after penile implant surgery, then it doesn't shroud the corporal bodies, and that's when it represents a problem. The management options, well, what about erectogenic therapies? That's good for soft gland syndrome, but when it's a hypermobile glands falling off the corporal bodies, that's a problem, and most probably Muse, when it existed, or a PDE5 inhibitor will not work well. There is some literature on just skin excision and suturing the skin tighter. I don't understand how that would actually work. Cylinder resizing for short cylinders, distal corporal body redilation if you can't get into the glands. But really, we're here to talk very briefly about glandulopexy. And the keys, of course, very much like crossover to immediate correction or awareness and identification intraoperatively. These are the two techniques that I've seen most commonly in the literature. There are others. On the left-hand side is a paper we published many years ago, and then the Mayo group published this on the right-hand side. And I don't think it really matters which technique you use as long as you're correcting it safely. The keys are, I like partial disassembly. I like to take the glands off the distal corporal body so I can get my suture right underneath the lip of the glands, the proximal lip of the glands. Avoid the neurovascular bundle. I stay lateral. You saw that the Mayo Clinic guys go across the distal shaft of the penis, deflating the implant cylinders and pressing them proximally so that your transtunical suture does not impact upon them. And then I use permanent suture. With the not buried beneath the glands, I use 2,0-ethibond or Tycron, which is, if you didn't know, braided polyethylene coated with silicone. These are the only two papers I could find in the literature looking at outcomes. Loyola is our series, and then the Mayo Clinic series, Matt Ziegelman series. All of ours were post-penile implant. They were not done intraoperatively. It's when I arrived at Loyola, the VA system there were 10 patients, all post-implant, mean duration of 22 months post, all permanent sutures, 90% satisfied, and no sensation loss post-operatively on biothesiology. Matt's series had 15 patients, 67% were performed at the time of implant. Vicryl suture was used in 46% and ethibond in 54%, and half of the vicryl suture patients needed the glandulopexy to be redone. So I think one of the parting messages is permanent suture utilization. 9-month follow-up, all had appropriate glandular positioning. Take-home messages, the gland's anatomy and turgidity is essential for satisfactory intercourse, not necessarily successful intercourse, but satisfactory intercourse. Awareness and recognition of SST is key to management. Intraoperative management has its advantages, and key surgical considerations I've discussed with you, and thank you very much.